So we took the women's questions very seriously. One of the things that they did as a part of the study was for 15 years, they kept track every day of their menstrual cycles. So with a little calendar that fit in their purse or their appointment calendar, they made a symbol. They marked B if they were bleeding, if they had menstrual bleeding that day, or S if they had spotting, or they left the date blank if they didn't have any menstrual discharge that particular day. We were able to use those records to discern a pattern that suggested that approximately 2 years before women had their last menses, they started skipping cycles, meaning that instead of having menstrual bleeding every 29 days or every 30 days, their cycle length might double that. So they might have cycles that were 60 days or more, or even longer. And once women began that skipping, on the average, they had about 2 more years before their final menstrual period would occur. Now, in all studies of human beings, we know that there's a great deal of variability that's normal. So we found that 2 years either side of that estimate was about right. And we also found that there was a stage that was discernible before that period of time where women started skipping periods. And that was a stage that we call the early menopausal transition. Women began noticing that, and we noticed in their records, that their periods their menstrual cycles got to be about 1 week longer, or they might be off by a week or more before they started skipping. So this early menopausal transition stage also took about 2.5 years, and again with about 2 years on either side being considered normal. So women tended to go through this process where, first of all, they noticed that their periods were getting longer or shorter by about a week or more, and then as they got closer to their final menstrual period, they noted, and we noted, that they started skipping menses altogether. So their periods might be as long, their cycles might be as long as 60 days or 90 days. And some women had a very quick transition where all of this change occurred within a very short period of time of less than 2 years. Some women had a very long transition. It took them as long as 5 or 6 years to have all of these changes occur. And this has been a very interesting finding for the women who participate in our studies, because they now know that there's some sort of a time-bound experience for them. One of the other things that women really wanted to know about were questions about symptoms. And of course, one of the most common symptoms women experience in this time of their lives is hot flashes. They're very interested in what caused hot flashes, how to manage them, whether there was something that they could do that would help them avoid hot flashes. So in the work that we've done, we've looked at not only the occurrence of the hot flashes and how severe they were, but what factors were associated with them. And not surprisingly, we have found that follicle-stimulating hormone, which is produced by the pituitary gland, is associated with more severe hot flashes. So as that hormone rises, the hot flashes also become more frequent and more severe. Another hormone that's associated with hot flashes in our work is estrogen. And as our estrogen levels decline as we approach our final menstrual period, the occurrence of hot flashes becomes much more frequent.
And this has led you to recommendations regarding treatment or how to approach these changes in women's lives?
We're at a stage where we are looking at some additional results of the last 15 years worth of study in order to make some recommendations. One of the things, however, that we found is that it seems that with some of the recent results of the Women's Health Initiative study that suggests that hormone therapy is not a good way of preventing heart disease, and also is associated with higher risk of breast cancer in some women, and also is associated with increased risk of stroke, and especially of cardiovascular events like venous thromboembolism or blood clots, that the recommendation about using hormone therapy has been that women should use this, if at all, only if they have severe symptoms, and then only for as short a time as possible to manage the symptoms. In the U.S. now, there are a number of other studies that are being conducted looking at the consequences of treating women closer to the time that they experience their final menstrual period to see if those results would be the same. But given the conclusions of the Women's Health Initiative, which was the largest clinical trial ever conducted, and also the largest clinical trial using hormone therapy for prevention, I would be very cautious in suggesting that that would be the first choice of therapy for women. So as a result, there is a very renewed interest in alternatives for women to hormone therapy. One of the studies that a colleague of mine and I did many years ago involved looking at whether women could learn to control their hot flashes by using biofeedback. And in fact, what we learned was that women could get quite good at controlling hot flashes by using biofeedback, where they learned to control their body temperature and literally to avert a hot flash symptom. And others have been able to show the same results. So this is a potential alternative therapy for women.
Thank you for sharing this exciting approach that you have towards research. And I would like to ask you a little bit, to tell us a little bit about the University of Washington School of Nursing, which is a leading school in the United States and the world.
Thank you. It's my pleasure to tell you about the University of Washington School of Nursing. We have a school that has been ranked as outstanding in the United States now for as long as the rankings have been conducted. And I attribute that to having an outstanding student body, some exceptionally capable students, as well as outstanding faculty and staff. We have some of the leading scholars in the area of nursing in the world, I believe. And I believe that as a consequence of having the particularly wonderful mix of students, faculty, and staff, we are able to achieve some things that are quite exciting. Our school has a Bachelor's of Science in Nursing program that enrolls approximately 100 undergraduate students each year. We have a master's program in nursing that prepares nurses for advanced practice roles as nurse practitioners. That is a role in the United States that is associated with the ability to provide the full range of primary care for patients, as well as for providing some very expert care to people in hospitals with specific kinds of health problems. We also educate clinical nurse specialists, nurses whose focus is predominantly on a population of patients with certain types of health problems, for example, in cardiovascular disease. We have a PhD program in nursing science that prepares the next generation of researchers and educators and enrolls approximately 12 to 20 new students each year. Their research addresses some of the most vexing problems that face healthcare right now, ranging from the optimal care for preterm infants, those infants that can fit in the palm of your hand, to providing care for the oldest of the old, including studies done by some of our graduate students like Anna Zisberg, who is currently a member of the faculty at the University of Haifa. Anna's study focused on the role of routine in identifying ways in which older adults might be at risk for developing frailty and for limitations in their activities of daily living. So our research spans the youngest of the young to the oldest of the old, and every possible population in between. In addition, we have many visiting scholars who come to study with us from countries around the world and truly enrich the work that we do. We also have postdoctoral programs in which nurses learn the specific emphases on research methods in their areas of expertise.
And your faculty is engaged, of course, as a leading university in various research centers. Could you tell us a little bit about the research centers in your school?
Yes, we have 4 of them. One focuses on, one is a center for infant mental health and development. It has a very unusual focus and actually is the only such academic center in the United States right now. We have learned that infants can become depressed at a very young age when parenting problems exist. And often caretakers or caregivers or parents who are faced with profound life stresses, who are dealing with their own depression, who have a history of abuse in their own families, or who have substance abuse problems, find it very difficult to engage deeply with an infant. And as a mother, you and I both are aware of the fact that one of the most important things that we do with young infants is engage them in learning the predictability of caring for them by another human being. In other words, if they can get our attention and we can engage them, we can help them develop their little brains and learn social and emotional skills at a very young age. When a parent or a caregiver has his or her own emotional problems, it's very hard to engage deeply with that infant. So some of the work that's going on at the School of Nursing focuses on how we can help the caregivers or the parents of those infants learn better ways of interacting with them to promote their engagement and emotional development. We hope that the consequences will be a much lower level of aberrant behavior that causes children to have difficulty in school and also in other social relationships as they grow older. We have a study center called the Center for Women's Health Research that was one of the first such studies funded by the National Institutes of Health in the U.S. It began in 1989, and the Women's Health Research agenda for the National Institutes of Health in the U.S. was not developed until 1991. So you can see we were a bit ahead of our time. That center started out focusing on problems related to women's health across the lifespan, but particularly focusing on midlife and older women. We did studies, for example, of sleep patterns in older women that were among the first to be done in the nation. They involved studies of women during the menopausal transition and also studies of women 65 and older that told us a good bit about the role of menopause and the role of life stress and other sources of difficulty in women's lives as they influence sleep. We have now broadened the focus of that center to focus on gender differences so that we are now taking into account ways in which men and women differ in their experiences of health. We have a center that focuses on the advancement of research on health disparities. And in the U.S., this is a very important topic. As we become more and more aware of the diverse populations living in the U.S., we discover that there are some that are typically underserved or poorly served by our healthcare system, and who, for other reasons, experience very bad health. Excuse me. One such example is African American populations in the U.S. who, regardless of their current social status, income level, and education, still experience a higher risk of some health problems than we would expect. Certainly a higher risk than is experienced by white populations. So the work of this center focuses on attempting to understand the health needs and problems of specific populations residing not only in the Seattle and Washington state area, but also we have a collaboration with the University of Hawaii in which we are also studying populations in Hawaii and learning from them as well. We have a third center that focuses on population, and that is our Center for Healthy Aging. And the mission of that center is truly exciting because as we notice that the population in the U.S. and in the world as a whole is getting much older, that is, the proportion of elderly people in the population is increasing dramatically, we know that that portends some very specific challenges for our health services and for the adequacy of health services for people as they age. The focus of this center looks at what aspects of aging can be health promoting. So some of the work affiliated with that center that's being done by both students and our faculty engages older populations of adults in senior care centers in activity programs with the idea that maintaining muscle strength and doing strength training kinds of exercises can prevent the loss of function as people age. So those 4 centers are very deeply engaged in research that focuses on infants and their parents, on populations that experience disparities in their health, on women, and on more recently on men, and now on populations of older adults. So we seem to cover the lifespan with those centers. In addition, we have another center that engages students not only in educational activities, but also in some research projects. And that is a center for interprofessional collaboration. And this center helps health professional students from nursing, pharmacy, dentistry, social work, public health, and medicine study together so that at the completion of their academic programs, they have a deep understanding of one another's roles and responsibilities for the health care of patients in hospitals and in the community.
This has been a very interesting view of many research areas. Can you tell me a little bit more about your views for nursing research in general, your vision for nursing practice and research as you see it?
Well, our practice spans everything from community-based services for infants through older adults to the acute care, critical care settings where nurses are in the position of making life-saving decisions from moment to moment. So the need for our research is very broad and contains, I think, some unique contributions for healthcare. Certainly, the research that's done by our colleagues in pharmacy, in medicine, in public health, social work, and dentistry are extremely important, make extremely important contributions. The way in which nursing research differs a bit in our contribution is that we seem to have focused specifically on what the human experience is like to become diagnosed with a certain disease. For example, what is it like to now learn to live with diabetes? What is it like to learn to live with heart disease? What is it like to recover from surgery? What is it like to struggle as a resident in a community to maintain your body weight in a range that is healthy as opposed to overweight or obese that presents you with health risks? And we believe that by understanding the experiential aspects of health, we have a fuller understanding of the relationship between how people experience their health and also learn to live with or adapt to the circumstances that change as their health changes. We have found it very important to not only focus on the individual, although that certainly is a Western notion that the individual is the unit of healthcare delivery, but as important as understanding the individual is understanding the family and the social context for that individual. So for a woman who is newly diagnosed with breast cancer, we might learn that her main concern is not so much whether she's going to have side effects of the chemotherapy, but how she's going to get her children to understand that she doesn't have the same energy level as she might have had earlier, or how she's going to simply provide for their care when she's going through chemotherapy or radiation therapy. We also appreciate the focus of the broader social and biological and physical environment on people's health. We know that families who struggle to exist with marginal resources or who exist in parts of our community that are not well served by community services or health services for that matter are facing some deep challenges as far as being able to raise their children in a healthy environment and to maintain their own health. In addition, we think about what we refer to as clinical therapeutics. What are the therapeutic elements of a relationship that we have with clients, with patients and their families? What are the therapeutic agents? They may be medications, they may be other agents that we test in conjunction with trying to improve people's health.
And perhaps this will be our the final part of this conversation today. Would you, from your experience here, having arrived only a few days ago, give us some words of wisdom about where Israeli nursing, and maybe especially our relatively young Department of Nursing at the University of Haifa, where do you see it should go in terms of these challenges that you've discussed throughout this talk of practice and research and advancing the field of nursing?
It's a great question. I have a great degree of admiration for what the University of Haifa has achieved in the nursing program. I think that bringing nursing education into the academy, into a university setting, is an extremely important step in establishing the field, not for the sake of the field, but for the betterment of human health. Probably at the center of all academic nursing is attempting to do in the world now is to understand how to provide better services for people so that we can enhance the outcomes of healthcare and have the healthiest populations possible. We simply, as a society, cannot afford to have a large number of people with poor health. It is too expensive, both in terms of the human cost and in terms of the capital expenditures. The University of Haifa has a very important opportunity ahead of it. One of the most important next steps in nursing in the world is the movement towards enlarging the evidence base to guide our practice, to help us deliver the best possible service with the best possible outcomes for people. It is through deepening the understanding through research of our practice and of human health experiences that we can achieve that goal. I see the next steps for the University of Haifa as you look toward offering graduate preparation in nursing being an exemplary step in the achievement of better health for Israeli citizens.
This has been a pleasure, and I have certainly learned a lot from you and from this discussion. Thank you very much for it, as I'm sure our audience has. And I would like to welcome you again, and hope you enjoy the next steps and stages of your visit here. And thank you very much.
Thank you. I've had wonderful Israeli hospitality and have enjoyed being in your beautiful city.
Thank you. תודה רבה ושלום לכולכם.